Good afternoon, everyone. I'm primarily not a shoulder surgeon. At our center, we do about 15-20 reverse shoulders in a year. And primarily, our main load is knee and hip surgery in our center. So we are still learning, and many more experienced people will keep learning from them. So my case is a 56 years old gentleman. He was an ex-serviceman. He met with a road traffic accident last year in the month of June. And he sustained this proximal humerus fracture, which was comminuted, and for which he underwent an osteosynthesis at another center.
Are you running the slideshow, Dr. Gogoi? Is the slideshow on?
Oh, sure. Yeah. Okay. So yes, osteosynthesis was done in June 2021, but after that it continued to have pain and stiffness in the shoulder joint. He never got relief or improvement in functions. And so with this, he presented to our center in September 2021. And at that time, this was his status. If you see on the right side of the picture, this was a fixation, and we can make out there was some loose osteochondral fragment inside the articular surface, in between the articular surfaces. There's a fragment lying there. And the MRI reports showed there was tear of the supraspinatus tendon as well, complete tear, and the fragment lying inside. And important factors for us to consider in his case was he is a diabetic, he is hypertensive, he has high BMI, 31.2, and as I said, MRI showed this tear, and his age was 56 years only. And revision osteosynthesis was not a feasible option because of this kind of fracture and that fragment inside. So
did you do a CT scan?
CT scan was done, but thing is actually in our center, we have a very small team. We don't have meticulous record keeping.
No. So why I'm asking is, what you are saying, fragment into the joint, may not be in the joint. It may
the
be
MRI report
behind the joint.
Yeah, the MRI reports mentions that it is in the articular, inside the joint only. If you see here, displaced fragment, which fragment into the joint space between the articular margins. This report says that. So osteosynthesis was, we thought, is not a viable option. So now, coming to the discussion part. Like as we all know, reverse shoulder surgery cases are increasing, and dislocation of reverse shoulder also, the incidence is pretty high, 1.5 to the tune of 31% of dislocations. And as documented, the risk factors for instability in reverse shoulder are high BMI, which was in this case also high. Male gender itself constitutes as a risk factor. Subscapular deficiency, previous surgery, surgical approach, and then bone deficiency on either side, and previous trauma. And there are all these mechanical factors, biomechanical factors, which also play up in contributing to the instability. If soft tissue tension is not adequate, glenosphere diameter again also is an important factor. These all factors have been already discussed in detail, so I won't go into much details in this. And then, as we know, larger glenosphere diameter is supposed to give more stability and more range of motion, and eccentric glenosphere position, if we put it a little inferiorly, and it is supposed to give more stability and avoid inferior scapular notching. It prevents adduction impingement, and glenosphere lateralization, again, is case to case probably. It is supposed to give more stability, but at the cost of increased deltoid force required for the abduction movement. And the tilt of the glenosphere, inferior tilt of 10 degrees, is supposed to increase stability, which is again debatable. socket constraint. Of course, if we increase the socket constraint by increasing the depth, it gives more stability at the cost of limitation of range of motion. Humeral lengthening is an option to increase stability, and as Lederman in his studies showed, it improves active elevation and stability. And humeral lateralization also is an important parameter which decreases deltoid force while giving better stability. Neck shaft angle, if we have the option, then, but many times we don't have an option. With the designs available here, we have fixed neck shaft angles. And the version. Again, version of humeral stem and the glenosphere is still there is no consensus as per we know. Most of the times we give neutral version in the glenosphere and about 20 degrees of retroversion on the humeral side. Again, debatable. And implant removal and reverse shoulder was done. We used the prophylactic circlage at the proximal humerus, and we found good stability on table, and post-op rehab was started. But on day 4, the patient dislocated. And on asking, he revealed that he removed his shoulder immobilizer in the night, and we are just assuming probably he didn't keep the limb in proper position, and somehow it got dislocated. Close reduction was attempted, but it was not feeling stable again. Then he was taken up for open reduction with a plan for revision, and we kept options for retentive poly and humeral heightener and everything. Yeah.
Were you able to reduce it by close method?
Close reduction, it was coming to place, but it was not feeling stable. So we had to plan for open reduction and go ahead accordingly. And opening up, we found that the repair subscape was torn, and soft tissue was interposed between the surfaces. And we also found the stem to be loose. It was, initially we kept it in 20-degree retroversion, but it was in neutral version and loose. And
Dr. BIRAJ, can I ask you one question?
Yeah.
So you saw the patient with a plate on, and you found the supraspinatus tear in the rehab process, and I assume she was not able to lift at that time.
Sorry, sir?
I assume she was not able to elevate after the plating.
After the surgery? After plating?
First plating, yeah.
Yes, yes.
So what was the time frame when the patient was not able to lift the arm? 4 weeks, 6 weeks, 8 weeks, 3 months?
That was when he presented to us. That was already from June till September. It was
3-4 months.
4 months, yeah.
4 months. Yeah. So such patients may have rotator cuff tears, and with proper rehab are able to elevate. I have got 2 patients in which I deferred reverse shoulder, and with proper rehab they were able to elevate.
True.
My second point is, in your X-ray immediate post-op, can you just go back one slide please? Where is the greater tuberosity in this X-ray?
Sorry again?
Where is the greater tuberosity in this X-ray?
Lateral.
Greater tuberosity.
Because of this probably rotated view is not true AP, I think that's why it is not clear here. But subsequent X-rays, you'll be able to see when it is proper AP view.
All right. Okay.
Yeah. And regarding your first question, we didn't think about that it will improve with time, because the loose fragment was also lying inside the articular space, joint space. There was a loose fragment, bony fragment in the joint after the plating also. So that's why we assume that it is unlikely to improve without any intervention. So what we did was we cemented the stem in 20-degree retroversion again. And on table we used one femoral heightening block, and then we also kept retentive poly standby, but with regular poly only we found it quite stable again. And we did the remaining subscap repair to adjacent tissues and bones. And
you were able to pull the subscap to this shaft of the humerus?
Actually, nearest whatever tissues were there, we repaired to those, and made some holes in the humerus and then tied it there. And after that we found it quite stable on table. And then slow, gradual rehab was done after that. And at 15 months follow-up now, in the latest follow-up, when he came, he has no pain now, he has very good range of motion, and he is doing all his activities of daily living quite comfortably. Even he is saying that he picked up one bag of about 10 kg also with his hand, which we warned him not to do. And he said he is riding a scooty also now. That's the thing. So now I would like to know, I would like to learn what
just
better
one
things.
question
Sir.
I have. It dislocated in 4 days' time.
4 days time, sir.
How could you increase your offset so much in 4 days? That means on day one, were you not perfect with your soft tissue tensioning? Otherwise, how can you increase that gap so much?
That is one thing, yeah. But I was, we were thinking maybe subscap was a bit loose. Initially, we could repair the subscap in the first case, and it was feeling stable on table. But subsequently, when he dislocated on the first time post-op, most probably he got his subscap torn again because he removed his immobilizer, and while sleeping, probably he kept it somehow rotated externally or something. So that might have led to this laxity.
Normally, we test soft tissue tension without
Yeah.
repairing anything.
Yeah,
Subscap
normally
is
yes, normally yes.
incidental.
Yeah,
So normally
that's
once
true.
we put all the implants, we test the tension, dislocatability,
Yeah.
and it must be reasonably tight, and then you repair whatever you can repair.
Yeah,
So we are not dependent on repair for dislocation.
got your
right?
point. Yeah,
But after 4 days, you could put such a thick spacer in between.
got your
that,
point.
that
So
surprises
another factor which comes to our mind is probably subsequently when we opened the stem was also found loose. So initially on table which
Yeah, your
gives us the
stem
feeling
rotated.
of yeah,
Your stem was
rotated,
rotating.
and probably the height of the stem also must have changed. So
There was a
that might be
subsident
one
there.
factor.
Maybe the plane of anesthesia was also a bit deeper in a lighter note.
Sorry.
No, nothing. It was just a bad attempt at humor. So, so I remember reading an editorial by Dr. Chitranjan Ranawat in JBJS. He is speaking on total hip replacement, and the title of the editorial was "The Legs Too Long and the Pants Too Short." And I think with increasing humeral head heights, we are going to see the upper limb variant of it: the sleeves too short and the arms too long. So I think that is something we must be prepared to see. Upper arm asymmetry, of course, is less visible than lower limb asymmetry.
True.
But what is the acceptable level of arm lengthening? Dr. Maheshwari, if I can ask you, is there any published data, or Dr. Raman, if you can answer this question?
4 centimeter, anything goes beyond 4 centimeter, nerve injuries are there. But it all depends how tall the patient is. So that was the reason the RSA was not allowed in Japan, and that's how the superior capsular reconstruction originated, because when the trial run was done in Japan, the patients had too many nerve injuries. So it was not allowed by the FDA in Japan. Eventually, they are starting doing it now, but nerve injuries are very common after 3 centimeter, 3 to 4 centimeter.
But Dr. Raman, in the lower limb, in a lengthening of 2.5 centimeters, you have sciatic nerve neuropraxia.
See,
In
the normal play
upper
of
limb, are you sure about 4 centimeters?
Yes, I'm telling you, the sciatic nerve is 4 centimeter, the play of sciatic nerve by the anatomical textbooks. And I could not find evidence of the normal play of the nerves. And I've had all kind of nerve injuries. I've had a musculocutaneous nerve injury, I've had a radial nerve injury, and of course axillary are common, neuropraxia in my reverse shoulder replacements. So I'm very, very critical of the patient's height. I look at the patient and then I'm very critical of distalization. So I choose my distalization according to that.
And moreover, distalization has other flip sides also, like excessive distalization probably will lead to acromial stress fracture and deltoid
That is where the point is.
dysfunction. Yeah.
I think this patient is, how many months was this follow-up?
Now it is 15 months.
15 months.
15 months, yeah. Thank you.
Yeah.